Hi, my name is Dan, and I'm a mental health pharmacist, and today I'm going to be giving a presentation about bipolar disorder. There are three major sections to the presentation today. First, I'll start with some background and some history about bipolar disorder. Then I'll go into the guidelines and briefly review the treatment for bipolar mania, for bipolar depression, and for bipolar maintenance. Then I will go a little more in detail in some of the medications, and then finally I'll end with a summary slide. So without further ado, let's go into some background information. First, I wanted to start with a true or false question. So bipolar I means bipolar mania, and bipolar II means bipolar depression. So feel free to pause if you'd like to think about it, but the answer is false. So bipolar I versus bipolar II denotes a difference in severity. So patients with bipolar I fully meet the criteria for mania, whereas patients with bipolar II meet the criteria for hypomania. Bipolar I versus bipolar II does not denote a difference in the change in the poles, so mania versus depression. I wanted to start with a little history. So the original term for bipolar disorder was not bipolar disorder. So there was a manual used in psychiatry to standardize the diagnosing of mental illnesses. This is called the DSM, which is short for Diagnostic and Statistical Manuals of Mental Illness. We are currently on the 5th edition, but the first edition came out in 1952. In this edition, the illness was called manic depressive reaction, and this was actually subclassified under the psychotic disorders. Next, with the DSM-2, the disease state name changed a little bit to manic depressive illness, and it was now classified under the affective disorders. Finally, in 1980, the DSM-3 came out, and this is where it was first called bipolar disorder. This naming carried through into the DSM-4 and then currently into the DSM-5. So this slide here in the DSM-5 shows some of the different diagnoses under bipolar disorder. So there's bipolar I, there's bipolar II, there's cyclothymia, and there's even more classifications than just this. Bipolar I means that the patient meets the criteria for full-on mania. A vast majority of the patients who have bipolar I also have major depressive episodes. For bipolar II disorder, the patients have to meet the criteria for something called hypomania, which is a less severe version of mania, and also meet the criteria for major depressive disorder. And then a patient with cyclothymia has symptoms that are similar to mania or hypomania, but don't quite meet the threshold for hypomania, and have symptoms of major depressive disorder that doesn't quite meet the threshold for major depressive disorder. So let's go into a little more detail into the DSM-5, into bipolar I. More specifically, what does mania mean? So mania is an elevated, expansive, irritable mood lasting at least 1 week. That duration of 1 week is thrown out the window if the patient is so severely ill that they're admitted to the hospital. In that case, a patient can have these symptoms for just a day or two, but if they go into the hospital, it's automatically considered full-on mania in bipolar I disorder. After criteria 1, some other symptoms have to be met as well. So I highlighted a few of them, including decreased need for sleep. So the phrasing and the terminology here is important because it's not just that the patient can't sleep, that could just be insomnia, but it's that they aren't sleeping and they don't feel tired afterwards. Next could be racing thoughts, flight of ideas, talkativeness, pressured speech. Next is increased in goal-directed activity. So patients with full-on mania will often start many projects and not follow through with them, so it can be not always all that productive. For example, they might start to clean their fridge and take all the food out, but stop midway through. They might start to write an essay, but it's kind of distractible and all over the place. They might start a business idea and take out a loan, but not follow through with it. So it can be destructive goal-directed activity. Otherwise, though, some patients with mania and some patients with hypomania can be quite productive and get a lot done during a hypomanic or manic state. Next is risky behaviors. So risky behaviors are also common in mania. So risky sexual behaviors, risky financial behaviors, things like that. Let's compare this to bipolar II. So what hypomania is. Hypomania is the same thing, but less severe. So elevated, expansive, irritable mood lasting at least 4 days as compared to a week. The rest of the symptoms are the same as the symptoms for mania, but again, less severe. It can't impair functioning as much. The patient can't go to the hospital or have psychotic features, or it's usually considered full-on mania. For the depressive side of bipolar, it is the same criteria as it is for major depressive disorder. So suicidality, changes in interest, guilt, appetite, movement changes, concentration changes, sleep changes, and so on. Cyclothymia is, again, the patients don't quite meet the criteria for hypomania but have some of the symptoms, and don't quite meet the criteria for major depressive disorder but have some of the symptoms. Additionally, these symptoms last for quite a long time, so at least 2 years. There are some other subcategorizations in the DSM-5. So one is substance and medication-related bipolar disorder. And this is really important because you can't make a diagnosis of bipolar disorder if the patient has substances in their system. A patient can have stimulants, cocaine, methamphetamines, things like that can cause the symptoms of mania, and that patient doesn't have bipolar disorder, they have the substance in their system. Similar things goes for depressants, which can cause symptoms of the depressed side, and withdrawal. Substance withdrawal can cause a lot of these symptoms. Additionally, it doesn't have to be illicit substances. Corticosteroids, immunosuppressants, other drugs can cause these symptoms. Next, medical conditions can also cause some of the symptoms of bipolar. So getting a really good history, collateral information from the patient's family and background is really important. So does the patient have thyroid dysfunction or something like that? Finally, the DSM has other specified bipolar, which is kind of like a catch-all if the patient doesn't quite meet the criteria for the rest of these. So test your knowledge. Patients with bipolar disorder spend more time in a manic state than a depressed state. So again, feel free to pause and think about it. But the answer is a depressed state. So the patient spends most of the time in euthymia. So about 50% of the time their mood is okay. Their mood is in euthymia. About 40% of the time the patient has some characteristics of a depressive symptom. So it could be mild, could be moderate, could be severe. And only about 10% of the time is the patient in mania, typically. And as you can see from the image on the slide, this carries through with both bipolar I and bipolar II. Another term that's important in bipolar disorder is rapid cycling. So rapid cycling with bipolar disorder is that the patient has 4 mood episodes within 1 year. So a patient who tells you that they're feeling manic 1 minute, depressed the next, angry the next, happy the next, may not have bipolar disorder. They may have something like a personality disorder. So it would be very rare in bipolar disorder for a patient to feel manic one day, depressed the next day, manic the next day, and so on. So again, it's really important to talk with the patient and get lots of information. Differential diagnosis can be quite extensive in bipolar because many other disease states cause a lot of these symptoms. So does the patient have ADHD? Do they have depression, a personality disorder, a psychotic disorder, substance use, or do they have bipolar disorder? So the history is really important. Do they have mania or do they have hyperactive delirium? Do they have dementia? Do they have Cushing disease, multiple sclerosis, MS, steroid use? So there's many other disease states that can cause these symptoms. So again, a history is really important. Another thing that's important in bipolar disorder is what's called measurement-based care. So we don't have an objective lab value that we can use to denote changes in bipolar disorder. So going through a scale that can give a patient a score helps you to track changes over time. So a scale for the mania side is the Young Mania Rating Scale. A scale for the depressed side is scales used in major depressive disorder. So this can help you track any changes with the patient over time. Next is etiology and pathophys. So bipolar disorder is one of the most heritable mental illnesses. So there's a really big genetic link in risk with bipolar disorder. Next, interestingly, bipolar disorder shares more genes, at-risk genes, with schizophrenia than bipolar disorder does with major depressive disorder. So the first DSM classifying this under psychotic disorders may have been onto something. The neuroanatomy is quite complicated with bipolar disorder. Mostly the changes are seen in the subcortical areas, but this is again quite complicated. Next is some of the neurotransmitters, hormones. Again, is quite complicated. Many things are implicated. So dopamine, norepinephrine, GABA, glutamate, BDNF, G proteins, many things are implicated in bipolar disorder. So it's quite a complicated disease state. Next, I wanted to look at racial disparities in bipolar disorder. And I wanted to start with a misdiagnosis difference. So patients with bipolar disorder who are Black and Hispanic are more likely to be initially diagnosed with schizophrenia as compared to white patients. Next is medication differences. Black patients are more likely in the 90% to initially start on an antipsychotic, whereas white patients start on an antipsychotic with bipolar disorder about 60-something% of the time. Next is follow-up differences. So within 90 days of receiving a diagnosis of bipolar disorder, Black patients are seen for follow-up about 13% of the time, whereas white individuals are seen about 87% of the time. So it's really important to be aware of these differences. Next is non-pharmacologic treatments. So we often think about using medications for bipolar disorder, and they're quite helpful, but knowing the non-pharm treatments are helpful as well. So first is psychotherapy. So therapy is often used for depression, anxiety disorders, PTSD, but it's also helpful in bipolar disorder. Nutrition, exercise, and sleep are quite important. Bipolar disorder has been shown to have a low-grade chronic inflammatory state. So proper nutrition, exercise, sleep helps with this. Finally, for refractory cases, sometimes electroconvulsive therapy is used, and it's about 70% effective in bipolar disorder. Now let's go into the second major section of the presentation, which is treatment. First, I wanted to start with a question. So think about the answer to this, but what are first-line options for acute bipolar mania? So again, feel free to pause, think about it, and we'll go into some of those options right now. I wanted to start with a comparison of some of the guidelines. So I have the World Federation guidelines, which is considered international guidelines. I have the CANMAT Canadian guidelines, the NICE guidelines from the UK, and also the British guidelines. So you can see there's many options and there's some patterns that you can see. So feel free to pause and take a look at this slide, but I'm going to boil down some information. So what you'll typically see, or patterns that you can see in the first line recommendations, are the guidelines in general say to use a second generation antipsychotic. Two of the guidelines have one first generation antipsychotic called haloperidol. Many have lithium and many have valproic acid. So the guidelines look very difficult to start with, and there's a bunch of different options, but this is kind of what you can boil it down to as first line options. Additionally, for more severe or refractory cases, you can use combinations. So for example, you can use a second generation antipsychotic with lithium, or a second generation antipsychotic with valproic acid, and so on. Listed here are your FDA-approved options for bipolar mania. So many antipsychotics are, and a few mood stabilizers are. Of note, some of the first-line recommendations in the guidelines were antipsychotics that are not FDA-approved. So pretty much any antipsychotic will help someone get out of an acute manic state. So you can go off-label if you would like for acute mania. Your goal here is rapid control of behavioral symptoms, sleep restoration, and agitation. The reason why it's rapid is because mania is harmful and damaging to someone's brain. You want them to go back to euthymia as quickly as possible, so it helps to prevent progression of the disease state. Some principles follow the guidelines to start. So start lithium, valproic acid, a second generation antipsychotic, or a combination. Benzodiazepines can be helpful in the initial phase, in the acute phase, especially if the patient's really agitated or something like that, but this isn't typically a long-term medication for bipolar disorder. Next, you want to typically discontinue stimulants and antidepressants when possible, as they may have worsened the mania. Next, what are first-line options for acute bipolar depression? So again, feel free to pause, think about it, and let's go into the guidelines again. So looking at the same guidelines for the depression end, you'll see some patterns as well. So again, feel free to pause if you want more detail, but this is just going to guide our general ideas of how to treat bipolar depression. One thing to note is that you won't see antidepressants as first line, sometimes as second, sometimes as third. The only exception being fluoxetine when used in combination with olanzapine. And we'll talk about why in a little bit. But typically you don't use antidepressants to start. So if you boil down these guidelines, here's what you're left with for the first line options. So now it's select second generation antipsychotics. So this is unsimilar to Bipolar Mania, where you can pretty much select any antipsychotic and it's going to help. For bipolar depression, you really want to remain on label for reasons we'll talk about. Next is lithium and Lamotrigine. So these are the first line options. So bipolar disorder can be quite intimidating for people who are unfamiliar with it, but really when you boil down the guidelines, it doesn't seem as intimidating. So remember, for bipolar mania, second gen antipsychotics, lithium, valproic acid, or combinations. For bipolar depression, select second generation antipsychotics, lithium, and Lamotrigine. So you can really boil these down so it's a little bit more simple. Here are your FDA approved options for specifically bipolar depression, and it's just antipsychotics that have this formal FDA approval. This is important to note because, again, you don't want to go off-label for the bipolar depression side with the antipsychotics. So really picking between these ones can be quite helpful. Next is the goals here, your acute bipolar depression treatment and goals. So you want rapid control of behavioral symptoms, sleep restoration. So just like how the mania side can be harmful for the brain, so can the depressive side. So you really don't want your patient to be depressed for long periods of time, as that can be quite harmful. Principles: start these first line recommendations: Lamotrigine, lithium, select second generation antipsychotics. Antidepressant use is controversial, but should not be used as monotherapy and typically should not be used as a first line treatment. So I did say there was an exception. So in the first line recommendations, there was a specific combination product. The brand name is called Symbyax, and this is olanzapine and fluoxetine in combination. Olanzapine is a second generation antipsychotic, and fluoxetine is an SSRI antidepressant medication. So the reason that they use this and recommend this first line is first, efficacy. So a study showed that olanzapine was more effective than placebo in treating bipolar depression. But this same study found that olanzapine and fluoxetine in combination was more effective than olanzapine, which was more effective than placebo. So the combination is better than olanzapine alone. And the reason why might surprise you. So it's not really due to the SSRI effects of fluoxetine. So what fluoxetine and olanzapine do is they have a synergistic effect, and this effect helps to boost dopamine and norepinephrine in the front part of the brain called the prefrontal cortex, which can be quite helpful in treatment refractory depression and in bipolar depression. In fact, the combination product caused less of a serotonin release than fluoxetine alone. So again, this combination really isn't due to the SSRI effects of fluoxetine, just this synergistic effect. And that's why this antidepressant is okay, first line, when used in combination with olanzapine. So we talked about acute bipolar mania, we talked about acute bipolar depression, but what happens in maintenance? So the patient's stable, what do you do? So here's the same guidelines we looked at before, and there's some patterns we can see again. So what it's gonna boil down to is essentially you continue the patient on the medication that they were stabilized on. So a second gen antipsychotic, lithium, Lamotrigine, valproic acid or its derivatives, and so on. Here are some FDA approved options. Some are antipsychotics, some are mood stabilizers. But again, this is specifically being FDA approved for bipolar maintenance. Your goals here are to prevent adverse reactions, optimize treatment, stabilize the patient, and prevent polarity switching. So your principles here are generally whatever the patient was stabilized on, you're going to continue for a time period. at least generally a couple of months, 2, 3, 4 months. After that time period, if the patient's, say, on a combination, say risperidone and lithium, you might taper the patient slowly off the risperidone, the antipsychotic, and just leave them on lithium. So essentially, once the patient's stable, you want to simplify their medication regimen. You want to also consider decreasing the dose. So higher doses are often needed to stabilize someone out of mania, whereas lower doses can be used for maintenance. The final major section of the presentation is medications. So I wanted to go into a little bit more detail into the medications and talk about them further. So first we'll go into mood stabilizers. We'll start with lithium, valproic acid, lamotrigine, and carbamazepine. I wanted to start with a question. Which two medications have been shown to decrease suicidality? So take a minute to pause, to think about the answer, and I'll give the answer now. The two medications are actually lithium, which has been shown in bipolar disorder to decrease suicidality, and clozapine, which has been shown in schizophrenia and schizoaffective disorder to decrease suicidality. Of note, none of the antidepressants have, so it's these mood stabilizer and antipsychotic that have. So let's talk about lithium for a little bit. So lithium is a mood stabilizer. It's element, it's on the periodic table, it's natural, it's a metal, there's plenty of things about lithium. Its place in therapy is many different stages of bipolar disorder. So you can use it for mania, bipolar mania, bipolar depression, bipolar maintenance, and then it's used off-label as a major depressive disorder adjunct. So it has a few uses. Its mechanism of action is quite complicated. It probably works on brain-derived neurotrophic factor, which is like fertilizer for brain cells. It works on serotonin a little bit, it works on dopamine a little bit, and it works on GABA a little bit. So it's quite complicated, but it seems to be helpful in some patients. An interesting thing about lithium is, like I said, it's a natural element, and it's in the drinking supply. It's in some water supplies. So here's a map of the United States where there's different concentrations of lithium. A few interesting studies have taken place in regards to this. So a trial looked at different counties in Texas and looked at which counties had the most lithium in the drinking water and which had the least. And accounting for changes in socioeconomic status and so on, the counties with the most lithium in the drinking water had less violent crimes, homicides, suicides, rapes, and so on. So a little bit of lithium in the drinking water may be helpful for some patients or some people. Next, you can actually buy lithium over the counter. It's a low-dose product called lithium orotate that is available in 5 milligram amounts. As you can see, this differs very much from the starting prescription dose, which is 300 milligrams 2 to 3 times daily. So that 5 milligrams is quite small. But your goal isn't necessarily the number with lithium, it's the serum level of lithium. So you want to draw blood and check a level. The reason that this is important is because lithium has a narrow therapeutic index, which means that the amount that's needed for the drug to be effective is very close to the amount where the drug is toxic. So you have to monitor this quite closely. Your goal is 0.6 to 1.2 in general. You want to draw your level 12 hours post-dose, whether the patient's on lithium once a day, twice a day, or so on. When tolerated, lithium can be given as a once daily dose, and it should be given as a once daily dose. The reason behind this is it is less harmful to the kidneys when given all at once rather than giving consistent doses more often. The onset of action for mania is about 6 to 10 days. For depression, it can take quite some time, which is similar to many medications used to treat depression. Lithium's pharmacokinetics are linear. So what this means is if you double the dose, you will typically double the level. So it makes calculations with lithium quite easy. For example, a patient's on lithium 600 milligrams at night, their level's 0.4. If you want it to be 0.8, you would double the dose to 1200 milligrams. Your body can mistake lithium for sodium since they're both similarly seen by the kidneys. So maintaining adequate hydration is important. Next is a test your knowledge drug interactions question. So name a medication class that can significantly change the serum concentration of lithium. So again, pause, think about any drug interactions you can think about, and here's the answer. So common medications can affect lithium concentrations and quite severely too, so about like by 30 to 60%. NSAIDs, like for example ibuprofen, can increase lithium level. So this is important to talk about with your patient and important to know if they're taking an NSAID. These interactions aren't contraindications, it's just something you have to be more aware of so you can check their level more frequently. ACEs and ARBs, which are blood pressure medications, also increase lithium level. This can be a delayed effect as well, so you won't see it right when someone starts an ACE or an ARB, it could be a couple of weeks later. So again, increased monitoring is quite important. Diuretics, depending on the type, can change lithium's level. So thiazide diuretics often increase, loop diuretics sometimes decrease, and potassium-sparing diuretics typically don't affect lithium's level too much. Next, caffeine. So a patient's in the hospital, they're not drinking their daily coffee, and maybe once they leave, they start again, it can change lithium's level. So caffeine can decrease lithium's level. So knowing these interactions is somewhat important, but especially checking drug interactions is very important. So you don't have to have it memorized, but knowing to look can be quite helpful. Next are some of the side effects. So I was taught to go from the top down. Start with alopecia, which means hair thinning or hair loss. This can happen about 19% of patients. It's more common in female patients. Next is dermatologic. So about a third of patients report an increase in the number of pimples or acne. Neurologic side effects can happen like tremor, dizziness, things like this, but it's more of a risk in lithium overdose. You can see neurologic issues. Thyroid dysfunction is common. Again, not a reason to stop lithium, but you may have to start something like levothyroxine in a patient. Cardiovascular conduction changes can occur in about a third of patients, so something to be aware of if a patient has a cardiac history. GI issues like stomach aches and so on can happen as well, so sometimes the ER product can be a little easier on the stomach. Chronic kidney disease is quite important as well, and you monitor creatinine clearance, BUN, and kidney function quite frequently when a patient's on lithium. Polyuria, which means urinating frequently, polydipsia, which means increased thirst, can often happen with lithium. Your warnings and precautions on the lithium label, which are more severe things to look out for, are lithium toxicity. Again, it has that narrow therapeutic window, Brugada syndrome, which is a cardiac condition, and increased Epstein's anomaly, which can happen in the first trimester of pregnancy. Contraindications can be seen here and include some of these organ systems that you're worried about, like the kidneys. Toxicity depends on how severe the toxicity is, and it can vary from just supportive care all the way to hemodialysis. Here's some of the monitoring with lithium, so feel free to pause if you want to see more information about it, but I just wanted to highlight a few things like the renal function test and the drug level. So you're going to get this quite frequently when you start until you establish a baseline. So after lithium, another important drug to go into more detail is valproic acid and its derivatives. Valproic acid has a pretty interesting history. So a scientist in the 60s was testing seizure medications. He needed a solvent to dissolve the different medications in, and he chose valproic acid. So he dissolved medication A, B, C, D, and so on, all in valproic acid, and then realized that none of the participants in the study were having seizures. And he was confused by this until he found that it wasn't necessarily the drugs he was testing, but the solvent that he thought was inert was actually working and decreasing the seizures in all these patients. So valproic acid was originally developed as a seizure medication. And then in some of these patients who had mood instability, it was shown to help stabilize their mood. So just by chance, valproic acid was shown to be helpful for seizures and for bipolar disorder. One other thing to note with valproic acid are there are many derivatives with it. So valproic acid and sodium valproate can be used in different percentages, but you'll hear words like valproic acid, Depakote, Depakine, and so on. They're kind of lumped together because sodium valproate and valproic acid are all metabolized to valproic acid eventually. So this is an anti-epileptic drug, but also a mood stabilizer. Its place in therapy is more of the mania side of bipolar, less of the depressed side, though there is a little bit of evidence there. And then maintenance. Outside of bipolar disorder, it can be used for epilepsy, migraine prophylaxis. Its mechanism is it normalizes sodium and calcium channels, and it increases GABA concentrations. So just like how lithium has a level range that we target, so does valproic acid. So first question is, what is the goal level range for valproic acid in seizure disorders, and what is the goal level range in bipolar disorders? So take a minute to pause, think about it. But the goal level range for seizures is 50 to 100, whereas the goal level range for bipolar disorders, as listed in the package insert, is 50 to 125. So some hospital systems, when valproic acid gets past 100, will mark it as red, as being too high. So say the patient has a level of 110, it might say too high. But if the patient's using it for a bipolar disorder, this isn't too high, this is within range. Of note, further studies have interpreted that 50 to 125 a little further, with around 70 is where that level separates from placebo, and around 90 is where that level is most helpful in bipolar disorder. So you may need to target higher doses in bipolar disorder. Here's some of the dosing information. There's a few ways to dose valproic acid. Weight-based is common, and you have to dose a little bit higher with the ER product as it's a little bit weaker than the other products. And again, you're going to titrate to a goal serum concentration and to effect. So 50 to 125, draw a true trough. If you don't draw a true trough, it's important to interpret the level. So if it's drawn early, you might expect the level to be a little higher, and so on. The effects on mania can be seen quite quickly, so within 3 days, which is a little faster than lithium. Its pharmacokinetics are not linear, so you can't double the dose to expect a double in the concentration. You have to be a little more cautious. Its interactions can be seen here. The most significant one I wanted to highlight was carbapenem antibiotics, for example, meropenem. In fact, meropenem is used as an antidote. It's so effective at decreasing valproic acid level that it's used as an antidote for valproic acid poisoning and overdose. It can also affect warfarin and lamotrigine, so run drug interaction checks if you're going to use a valproic acid product. Side effects can be seen here. So there's many similarities to lithium in some of the side effects, like alopecia. Some differences are dermatologic. Valproic acid is known for rashes as compared to acne. One other difference is with lithium, you're concerned about the kidneys. With valproic acid products, you're concerned about the liver, so you check liver function tests. Next, pancreatitis can occur and thrombocytopenia can occur. The warnings and precautions can be seen here. All anti-epileptic medications have a warning for increased risk of suicidality. Contraindications can be seen here. Again, I wanted to highlight the hepatic or the liver issues that valproic acid can cause or worsen. Toxicity depends on the level and again ranges from supportive care to that reversal agent due to the interaction, meropenem. Here's some of the here's some of the monitoring. So again, level and hepatic function are what I wanted to highlight. Lamotrigine, or brand name Lamictal, is the third drug that we'll go into. So this is also an anti-epileptic medication, but it's used as a mood stabilizer in bipolar disorder. Its place is more on the depressive end, so bipolar depression, bipolar maintenance, whereas remember for valproic acid, it was more for bipolar mania or bipolar maintenance. The reason that this is used in bipolar depression is a specific reason that we'll talk about in a little bit. Its mechanism of action is that it blocks voltage-sensitive sodium channels, modulates glutamate release. So why must Lamotrigine be titrated to an effective dose rather than just starting at an effective dose? So feel free to pause and think about it. And the reason is it must be titrated up, and its dosing can be seen here because Lamotrigine has a high risk of serious rashes. That risk is higher the more quickly the dose is given. So it used to be started at higher doses, and then some patients would develop severe rashes, something called Stevens-Johnson syndrome. So nowadays we have a really slow titration. First 2 weeks, 25 milligrams. Next 2 weeks, 50 milligrams. The following week, 100 milligrams, and then the week after that, you can go up to 200 milligrams. So this is why it's typically not used for mania, because it takes a time period for it to get to an effective dose. So most of the studies are for bipolar depression, and that's what it's used for. Pharmacokinetics, one important piece of information to know is that if Lamotrigine stopped for a time period, you should really follow that retitration schedule to again limit the risk of rash. Some interactions can be seen here. There are more interactions, but these are just some ones that I wanted to highlight. So estrogen containing products and valproic acid, which we talked about before. Side effects can be seen here. So other than the rash, Lamotrigine's pretty well tolerated. One thing to note with the rash is that about 7% of patients will develop a benign rash, meaning just like a regular rash that kind of goes away. The problem is the second providers see that, they'll generally stop the medication because they're worried about the progression to a more serious rash. And I understand that completely. But 7% get the benign rash, 0.07% get Stevens-Johnson syndrome. And that risk raises if the titration schedule isn't followed. Contraindications are hypersensitivity, and with toxicity, Lamotrigine has a relatively mild toxicity. Here's some of the monitoring, so it's a little bit more straightforward than lithium and valproic acid because you don't typically get levels. The final drug I wanted to go into detail is Carbamazepine, brand name Tegretol. This is also sometimes used for seizures and is used as a mood stabilizer. Of note, this is generally a second or third line option, not a first line, and there's specific reasons for that. Its mechanism of action can be seen here, modulating sodium channels and decreasing glutamate release. Its dosing starts at sometimes 200 milligrams twice daily, but you have to increase the dose for the next following couple of weeks. The reason for that is that carbamazepine is what's called an auto-inducer. So your liver has specific enzymes, they're called CYP enzymes, and carbamazepine makes the enzyme that metabolizes it stronger. So over time, carbamazepine will make your liver better at clearing carbamazepine. So you have to increase the dose a few times until you fully induce that liver enzyme, and then you can keep the patient on a stable dose. So that's one of the major interactions and difficulties with carbamazepine, is that it's a CYP3A4 and 1A2 inducer. So again, these are liver enzymes, and many drugs and substances and over-the-counter products are all metabolized. Many of them are metabolized through CYP3A4 or 1A2. So carbamazepine is going to interact with a lot of things. So always run an interaction check. Some other things, but of course run an interaction check: hormonal contraceptives, antipsychotics, anticoagulants. Next are some of the side effects. So there's some severe rashes that can occur with carbamazepine as well. And there's some other side effects noted here as well. Hyponatremia is kind of unique to carbamazepine. Some contraindications can be seen here: bone marrow suppression, hypersensitivity, and so on. So one question with carbamazepine is genetic testing must be completed before starting carbamazepine in people from what descent? So pause, take a minute to think about it. And the answer is patients of Asian descent, you have to do a genetic test for a specific thing called HLA-B1502. Patients who have this gene are at a much higher risk of developing a severe rash from carbamazepine use. So always test for this in Asian patients before, or Asian descent patients before you start this medication. Monitoring can be seen here, so it can be a little bit complicated as well, and sometimes you do get serum drug concentrations, but this typically isn't used as much in bipolar disorder, more in epilepsy. Some other mood stabilizers are carbamazepine's cousin, oxcarb, which has limited evidence, more hyponatremia than carbamazepine, but maybe a little less drug interactions. Topiramate you may sometimes see, brand name Topamax, but again off-label, not a ton of evidence. And gabapentin, brand name Neurontin, not a lot of evidence, occasionally, pretty rarely seen. Finally, I wanted to highlight a few things about the antipsychotics. So second generation antipsychotics are generally preferred over first generation antipsychotics. You can use many of these for bipolar mania, select agents for bipolar depression, and some of these for bipolar maintenance. The reason why I have highlighted select agents for bipolar depression is that some agents have been shown not to be helpful. So here's a study about aripiprazole, brand name Abilify. Aripiprazole is FDA approved and useful in bipolar mania, FDA approved and useful as an adjunct in unipolar depression, but it doesn't seem to work for bipolar depression, at least according to a few studies. So this trial here showed that there was no difference than placebo at week 8 with aripiprazole in bipolar depression. So the point here is to stick to the FDA approved ones for bipolar depression. Next, a few things to highlight about the antidepressants. So the first thing about antidepressants in bipolar disorder are the efficacy. Do they work? And do they switch the patient, meaning switch them from bipolar depression into bipolar mania? So let's look at a little bit of evidence here. So I looked at 2 meta-analyses, which are a grouping of a bunch of different studies into a single study. And what both of these showed was that antidepressants are safe, but they're really not helpful. They really lack efficacy in bipolar depression. Safe meaning that they don't typically switch the patient into mania. This may not be true if the patient's taking the antidepressant alone. If you use an antidepressant in combination with a mood stabilizer, then you typically don't switch the patient. So the evidence behind antidepressants in bipolar depression is pretty low, but you'll still sometimes see it used in practice as a down-the-line option. Next, I wanted to further highlight the switch to mania. And again, antidepressant monotherapy may increase the risk, but it seems like antidepressant use in combination with a mood stabilizer does not increase the risk. So efficacy-wise, switch risk-wise, we reviewed. So the recommendations are only use during the acute depressive illness side. You don't want to use antidepressants during the mania side. If you're going to pick one, SSRIs or bupropion are preferred, and you want to use these in combination with an anti-manic agent. Typically, again, as like second, third, fourth line options, not as a first line option. Then you want to taper off after 3 to 6 months of remission from the bipolar depression side and not keep the patient on this medication for forever. Some additional agents, I briefly talked about benzodiazepines, which can be used in the acute end for mania, acute agitation, and so on. First generation antipsychotics are effective for mania and agitation, but they may have more EPS than the second generation. So in summary, we talked about the different types of bipolar disorder, so bipolar I, bipolar II, cyclothymic, and so on. We talked about what time patients spend most of their time in, so euthymia the most, then depression, then mania. Then we talked about the treatment. So for bipolar mania, you can really boil it down to valproic acid, lithium, second generation antipsychotics. For bipolar depression, Lamotrigine, lithium, select second generation antipsychotics. And then for maintenance, you can use any of the above and continue the patient on it for a time period, and then simplify the med regimen. Then we went into a little more detail with the medications, with the mood stabilizers, the antipsychotics, and the antidepressants. So with that being said, I hope this presentation was helpful, and thank you so much for watching.